We'll start this afternoon's serious session now then. So just like to introduce our first speaker, talking about the final push to elimination and examples of innovation. And first of all, we have Colin Lawton, who's going to talk to us about patient postcode patterns analysis. Colin.
Thank you. Yeah, thanks everyone. Yes, Colin Lawton. I am the Northern Prisons and Scotland Manager. If I haven't already met you, nice to meet everybody. I'm just here to talk about a little bit of work which is really new to what we're doing in the prisons at the minute. And it's very much around postcodes. And it kind of like links into quite a lot of stuff that's went on this morning, which is also about sharing information. But sharing information from into the prison and then back out of the prison is kind of like what we're trying to do as a team. So, quite some time now, we've had a intervention in the prison called the Prison Follow Me. So most remands now have a Prison Follow Me in place. So this means all of our peers are generally sitting inside a clinic. So when a patient comes in, our peers are interacting with the patient straight away inside a clinic. We're now able to speak to patients directly. What we do inside the clinic is we are gathering good information from the patient. We're asking people where you live, where will you be returning to, which area have you come from. We can see by mapping areas of positive patients. So what we're trying to do is build a picture of where this patient has come from, what part of the place in the community they came out of. Patients starting on treatment while still on remand. We'll have patients supported into the Hep C community teams. We're dealing with medication pickup from prison. We do one-to-one education sessions in the prison. We now support to end the treatment SVR12s. We're using information and communicating with community services. Okay, so what all this means is that what we are now finding is that this links in really well with reinfections. So quick examples of some of the work. So with the Lancashire team, which I know are sitting up the top there, did a great piece of work around looking at postcodes of patients that have been on our Follow Me for probably the last 12 to 18 months. And we found out that we had 3 positive prisoners from the same street, from the same house, all found in HMP Preston. This information was passed to the Hep C community team, who are now working on a plan to go and knock on the door to offer advice and testing to those who live there. This house triggered the prison team to start and use to spot the risks intervention, which I'm going to show at the end of the slide. This is a great example of kind of like showing you that we're recognising that there's a street in this area that we need to go and do this intervention. And in Stuart's group earlier, we were thinking about how do we think outside the box? How do we knock on this door? How do we test everybody in this house? And how do we let the people in the house know that their house is getting used in the prison as a place where people live? The next example we came across was the Yorkshire street medication. Interesting what we found here, that we had 3 lots of medication picked up from 2 local prisons, 2 male prisons and 1 female, delivered to the same street to 3 different patients over the course of 3 weeks. We're being asked to deliver 3 lots of medication from prison to community, all within the S63 postcode. 2 of the individuals lived alone, but 1 had a partner. We highlighted the risks and the routes of infection to this couple, which led to the partner requesting a test. We looked at this as a hotspot. Information was given to the ODN, the community outreach van coordinator and the nurse who covers this area, and they are working out the best way to reach this particular underserved community to test and treat. We are aware that this specialist nurse who covers this area has started attending a community hub in the area and offering testing here. So kind of that was us finding an area really in Yorkshire that is just not, people off that street and that area are not going to services. And it's a good piece of work. Managed to do some testing in the house. In Hull, in June and July, over 4 weeks, we had 3 men all identified as positive and started treatment in HMP Hull, all from the Scunthorpe area. Same postcode area, all on Follow Me referrals. We managed to meet 2 of them at the gate and give them a mobile phone to make life easier for the Hep C Trust community, working to stay in touch and support them. Scunthorpe area is becoming an area of interest, a hotspot for positives in HMP Hull. So that's a good another piece of work that we managed to work out. Just a little touch on Scotland. So I manage the Scotland team. We have a Cephid machine up there now in Forth Valley, which is starting to do its thing. In Scotland, there's small pockets of villages around. So small village, Tilcultry. In Forth Valley, we recognised when running the new Step C project, we were getting positives from the same area. The team used the new Spot the Difference tool to help the engagement. After a conversation with CGL to discuss this area's actions, we put a focus on key workers with CGL and CADs to provide enough IEP when at appointments. We offered IEP delivery to the homes, as well as having a pre-made bag of works taken to the food bank so that anyone could use and get help. So just the barriers, you know, looking at this piece of work is the information is the key part. Information we gather, the information that the nurses gather, the information that the community team gather, you know, we need to all make sure we're sharing this information with each other. Prison Follow Me, a good example. All information is collected, prison numbers on there, the address, the date of birth, probation is being consented, there's risk identified. We have a good picture of this patient. The bad examples, which still happen today, is we sometimes get referrals or a blank and just have a name written on it. There's no information about the patient or they've started treatment. And it becomes a bit of a lottery how we have to then do that extra bit of work on the wings to try and get this information. So our peer workers are now in most clinics completing the Prison Follow Me forms, asking the questions, gathering information and removing barriers. The outcome, North East prisons, Yorkshire, Lancashire and the Merseyside prisons all have the Prison Follow Me pathway firmly in place. We now use the area codes and we're looking for hotspots. We are sharing the information with our community team, making sure that they know there's a hotspot. Alongside that, we've got the community team, prison team, ODN and the drug services and probation all working as one, which makes a big difference to a patient when we're trying to find them. And then the Spot the Risks is now what we are using, which is this fantastic tool which was used in the northeast area in the community. We're using this when we're sitting in clinics, opening conversations with patients and hopefully gaining a lot more trust so people will give us more info. And that is me.
Thank you very much. We're going to do questions for these three sort of rapid fire talks at the end of the three sessions. So next up, it's my pleasure to introduce Louise Wilkins, team leader of Health Shop, Nottinghamshire Healthcare NHS Foundation Trust, and Kieran Grant, who is not here. And you're going to be talking to us about the distribution of harm reduction kits in an acute setting.
Hi everyone, thank you ever so much for inviting us to speak today. So I'm really a small cog in a much bigger wheel, so I want to recognise and thank my colleagues from the hospital who really made this happen. So I work for the Health Shop, which is sexual health and harm reduction service based in Nottingham City Centre. And the innovation is to provide needle exchange for people who are leaving hospital. Oh, what do I press? Yay, okay. So I've been trying to get this off the ground for years and years. It's felt like a passion of mine, really. Has it moved on? No, hasn't. There we go. Struggled lots and lots of barriers getting into hospital because we're a service that offers Hep C testing. We felt a high prevalence of Hep C, and I say used to have. I don't think we've got the same levels of prevalence anymore. And anecdotally, we were seeing a large amount of reinfections as well. So we felt that getting adequate needle exchange equipment was key, really. And it's been kind of mentioned today as part of previous speakers. So we put the packs together and took things forward. So you can see from national research, and again, it's been discussed as previous speakers have said, the importance of adequate needle coverage, really, the impact on crack cocaine injection in terms of frequency of injection, and also the increase of direct sharing. So we put together a local strategy as well as the kind of national stuff, and there's some of the examples of some of the things we did there, really. But we felt that getting more kit out in different places was really, really important. So really thinking about the creative ways to get kit out at different times of the day as well. So as it says on the slide here, the innovation is the first of its kind in a UK acute hospital trust. So I don't work in the hospital, I work in a community. And I really struggled at times to understand, like I live in a harm reduction world, like my world is harm reduction. And I couldn't really understand kind of the barriers really to get these kits out. But like I say, the team worked really, really hard in the hospital to make it happen. And it was a massive opportunity to get harm reduction there. So we put together 4 packs with lots of different types of equipment, and people could choose those based on their need, all about reducing harm. And in addition to that, we also added foil. We've got sexual health packs as well, and the team are working really hard to get naloxone as part of that too. So we've really thought it was a great piece of work that really could make a difference. So here's the project plan, and like I say, I was a small bit in all of this really, so the hard work was done by the team in the hospital. So you can imagine the conversations backwards and forwards, different governance things, and like I say, in a world that I didn't quite understand. But the more conversations I had, I think a lot of it was to do with education. Again, it's been talked about barriers and stigma and judgment, not understanding why people use drugs, not understanding the risks really, and not understanding kind of what we needed to do. So we did a lot of work as our service in terms of training, so breaking down barriers. We did a whole kind of workshop with the staff. We got them to cook drugs up for injection so they could see where the risks were, obviously not real drugs. And what we want to do is build confidence, to have more informed conversations as well with people. There's still an issue with water. Again, I don't quite understand what the thing is about water. It's just water. It can make a massive difference if people are injecting, especially people who are homeless. But we'll get there, and you choose your battles, I think. So I firmly believe what the team's done so far, we can absolutely do it. So there have been 6 kits given out since its launch in January, and I know the outcomes don't look massive, but 6 is 6, that's 6 people, that's 6 harm reduction conversations, that's 6 packs that might have been times by 4 or 20, whatever the number of packs that person might have needed. It meant that someone's not had to directly share equipment. It means that someone's had, different, maybe they've had Citra, they've not had to use Jif Lemon, those kind of things that really reduce the risk, really. But I think the other bit that really stands out to me is people care. Like, this intervention is a caring intervention. I mean, conversations that, it's that relationship with people, really. My service users don't always have the best time in hospital, quite often face lots of barriers, lots of negativity, lots of discrimination. And I think the fact that someone's had the time and given something really positive for someone, it's worth its weight in gold, really, I think. So as I said, it's not been an easy process. And again, my bit was getting the kits out. I like say, it's my world, it's the easier bit, really. Like I said, the team in the hospital have had the hardest bit. So there is still the legal issue with water for injection. There's still, I think, lots to do in terms of breaking down barriers and stigma in hospital settings. Exchange Supplies, who made the kits specifically for the hospital, they've been brilliant. So they did lots of work around the governance process to kind of tick all the boxes that were needed. So what's next? So we're going to do an audit to see if there are any missed opportunities. Could packs have given out that weren't given out? Where were conversations? What happened to stop those conversations? I still think there's lots more education and training that needs doing within the hospital setting to kind of build that confidence, reduce the stigma, look at barriers, look at obstacles, etc. We want to get some service user feedback. So I work in the needle exchange, so I want to know my patients that maybe have been in hospital, did they get offered a pack? What was their experience? Did they take it? If not, why? Like I said, the team are working really hard to get in the naloxone, which is an absolute key innovation in terms of reducing drug-related deaths as well. And another key bit, I think, which is a brilliant idea, is to try and get kits to be given out through ED. So again, my service users will go to ED, maybe sit for 12 hours, give up and go. And it might be 2 o'clock in the morning where there's no pharmacy needle exchange open. So if we can get someone a pack, so they've not got to bang on the door and use somebody else's needle, then there's an absolute success. So I think it's brilliant. So as you probably can tell, I'm really proud of this. I'm super passionate about it. I think it's absolutely amazing. And I thank my colleagues who are in the room today who have made this absolutely happen. So thank you so much, and thanks for listening.
Thank you. So our third and final rapid fire talk is by John Fox from the West Yorkshire Peer Programme Manager with the Hepatitis C Trust. He's going to be talking to us about a HITT in forensic mental health hospital settings.
Thank you. Well, what do I press? Thank you, Ed. That one. Thank you. So my name's John Fox and I'm the Peer Programme Manager for West Yorkshire, and we did a high intensity test and treat in a forensic unit, a big hospital in Wakefield called Fieldhead. So for me, partnership working to improve the Hep C pathway, which was already in place, and staff awareness and treatment within the forensic unit, it's kind of close to my heart as well, mental health. Collaborating, so we had stakeholder meetings, where we had to have a discussion around governance. Actually, they talked about incentives, but because of cohesion, we couldn't use incentives because of capacity. So it was quite... So what we had to do then is we had to have a look at the aims and objectives of the training and testing and procedure and pathway in the clinical settings where we were going to go in. So through these stakeholder meetings, after this, I was invited up to speak to the ward managers. From the ward managers there, I was invited to have a look around the hospital, and I met some of the patients while I were up there. Meetings were facilitated with the National Hep C elimination team and South West Yorkshire Mental Health Trust, the Hepatitis C Trust, Spectrum, and the West Yorkshire Liver Care Operational Development Network, and the Leeds Clinical Nurse Specialists. So in April and May, 3 testing days were organised by the Leeds team and in collaboration with all the other partner organisations. And prior to the testing days, I delivered 3 hepatitis awareness training sessions to the staff. I think I trained 18 staff members at the unit. And when we went to test the patient group, that this had been fed back to myself and Brendan down here. So overall, myself and Brendan have trained 95 members of staff, and the feedback from that has been really good. So for me, it was kind of trying to educate the staff around transmission routes of bloodborne viruses. So method, on each testing day, we used the point of care testing antibody tests. We used to identify patients that might be antibody positive. We also had the Cepheid present to test for active HCV infections, and the liver fibrosis scan also. So before testing days took place, discussion between the clinical teams in Leeds and Pinderfield Hospital, Wakefield, took place for an agreed pathway for any individual who tested positive for HCV and PCR negative but had an elevated liver fibrosis scan, so score according to the local guidelines, so we could push them onto that pathway. Any positive PCR results, the aim was for the treatment to be commenced within 48 hours of diagnosis while we were in there. So overall, 95 tests were offered over 3 days, over 5 weeks, in 19th of April to the 17th of May. And if you can see, we had 51% accepted and 47% declined. We found 1 antibody positive. So we didn't get, how I'd say, a lot of positive results, but 5 had previously been treated and SVR achieved through the pathway that was already in place. So the conclusion, the collaboration between all teams helped to improve the understanding of the hepatitis C virus and also hepatitis B and HIV for staff at Newton Lodge, with the aim that they could support who had previously declined testing or were reluctant to access treatment in the future. So what we did there is that they had a very low uptake of people that were coming into the hospital to do to be tested. So Spectrum Health are now working on established bloodborne virus testing as part of a standard admission process and biannual health checks for all patients in their unit. The Hep C Trust peers, which we did, myself and Brendan went back in there and did a peer-to-peer session, which I think we had another 6 people. Positive communication between all teams involved in this project ensured that the patient who tested HCV positive, PCR positive in the future can gain quick access to treatment, reducing the burden of health inequalities in this population. So this is the feedback that we had from the manager of the Sue Threadgold on the impact that we'd had on the service users and the staff as well. And this is myself, Tracy, Sheila, Lizzie and Brendan who undertook all the testing and training. I'll leave it there. Thank you.
Great. So if we can take questions for each of the three previous speakers, if they want to come up so that they're on the live stream, visible to people, I guess. Thank you. So anyone in the audience? While we're waiting, okay, yeah.
I've got a quick one just to get us started. Just a comment about the inpatient harm reduction kits. That fantastic initiative and potentially enormously impactful. You know, every hospital in the country could adopt that, you'd think, relatively easily. I just, with a sort of academic hat on from it, it struck me that qualitative research, sort of really digging into why it worked, why it didn't work, and barriers, facilitators and so on, would be tremendously valuable for that project. Have you got a plan around that? Or is it something you've thought about? I know the Hep C Trust is sort of very much in the room, and they have a kind of research advisory group, and it just might be worth tapping into some of that to move it forward.
Do you want to just?
I think we've talked about it a few times about the right people in the right place. I think so. Because we tried this such a long time, and then I think it was the right staff being there who kind of could see the value of it and kind of kept pushing it. So I think, and in terms of a piece of research, I think the staff that pushed it and their reasons why, the hospital, and there's so much stigma and so many barriers in hospitals, I couldn't believe it. So I think there is a nice piece of work. And then service users' experiences, I think, is really, really important to hear. So I think it's a good idea. Give me a shout. I'm more than happy. I think anything we can learn from stuff or that'll improve care that we can replicate in other parts will be brilliant. So
Yeah, I think if you do manage to solve the naloxone discharge problem, that would be fantastic. Yep.
So we've solved it in some parts in the inpatient mental health hospital. So now we are able to give naloxone as part of TTOs for the inpatient mental health. And I think it's really close, isn't it, Sam, in terms of the physical acute hospital, ever so close. So we are getting there. And I think with the moment we just give out IM and we're moving to include nasal, and I think nasal will make a huge difference because people are less scared of needles than they are the spray.
It would be great to disseminate how you've managed to do that, I think.
Yeah, happy to help. It's about the person, isn't it? So why would you not?
Hi, Lou, thank you. That was great. A large number of our peers, paid staff and volunteers, kind of getting engaged and trying to find ways to distribute safer injecting kit. And I'm just wondering what your thinking is around active users being involved in that process as well.
So I think, as we were talking before lunch, weren't we, I think? So we've got a peer-to-peer naloxone programme where we've got peers with living and recent lived experience. So they're taking kit out as part of their naloxone dissemination in the wider area. But I think, it's like conversation I had before, people know the areas to go, but we've got to use all the resources we can and work collaboratively. So I totally agree, Danny. I think it's about involving everybody, and hopefully some experience from the service users that I'm seeing who've been in hospital can give us some information, good or bad really, about what worked and what didn't. Did anyone actually have a conversation with them? And if not, why not? So, yeah.
Sorry, we're asking lots of questions about the inpatient. So I wasn't clear on who was actually having the conversation and whose job it was to issue the kits.
So there's a nursing team, so there's the alcohol liaison team as part of the hospital team that kind of anybody that goes on to hospital that needs a script. So there's a team of nurses that will go and see people, kind of get people on OST if that's what they want, or maintain people. So as part of that, there's the conversation about the harm reduction pack. If they're injecting or smoke heroin, then they can have foil or needle exchange. So they're doing it. So my needle exchange provides the kits and the training and the information, and they kind of do it on our behalf, really. So yeah, the packs that you saw, and they're like the same as the pharmacy packs. So again, it's that standardisation. So it's what they get in a pharmacy. It's pretty much what they would get in the hospital too.
Just while we're just waiting for Rachel to get the microphone. So with the postcode monitoring, I don't know whether, have you managed to cross-reference that with, I don't know if your area's done the GP search tool, which looks at postcodes of people in primary care? Because it would be really interesting to see whether they are truly coincident or not, because that would be a nice sort of validation thing.
Say much on that because obviously we're at prison, but we do cross over with the community team, so it would be probably a link that we would have to do at some point. It's very early what we're doing, so yeah.
Yeah, and I'm just actually going straight back to the provision as well, because it was just making me think. So, you know, great presentations by everybody, but, you know, so what learning can we take from this? So people leaving prison, you know, fantastic that we're doing, you know, you kind of got the postcode and everything, but why can't we be giving people who leave prison? And should it be, you know, I'm trying to think, you know, so in prisons, does it come down from drug and alcohol services? And actually, maybe it should come down through healthcare, if it's coming down through alcohol and healthcare in hospitals. And then, John, you know, in terms of the forensic hospitals, is it something, do you think that they can? So is there some learning, maybe it's like Ryan said, a piece of evaluation around it, you know, learning that then could kind of roll it out across all services, because it's a really simple fix, you know, whether it's peers out in the community delivering NSP, but if you've got people going through, loved it, A&E, I mean, there are millions of people being tested through A&E that would be such a pickup. You know, so I guess, yeah, what other options have we got to roll it out more?
Do you know, I think in forensic units, because there's a lot of people that use stimulants and have past injecting, you know, so like for me, when we first went in there, we realised that, you know, like I was in them inpatient settings for 22 years in and out, and a lot of mine were drug use. So like when me and Brendan went in there, we seen a risk group. And there were people in there that said, you know, when they get out, they was go to use substance again, you know, because a lot of them self-medicate with it within there. So it's just, you know, even though it didn't yield a lot of positives, we're still educating staff members and a patient group that are very vulnerable in the community.
For me, it's really easy to give kit out in the packs. Staff didn't have to do anything. They have to have massive amounts of knowledge in terms of harm reduction. If someone's using needle exchange, they know what's in the packs, you know, and obviously it's really good to give extra harm reduction advice, but it was trying to reassure staff that you weren't going to make someone take drugs if you give them a needle exchange pack. That's not what's going to happen. All you're going to do is make it safer for people. So we've started giving out naloxone in custody suites. I would love to give packs out. That might be pushing it too far at the moment, but why not? Why not exactly what you said? There are so many. We've got rehabs when we know people are leaving and they're leaving really vulnerable. And, you know, if we could give needle exchange and naloxone at that point, then it reduces that risk, doesn't it, I think? But it's hard when you're on this side of the world and you get it when you're trying to promote something to someone that people just don't understand. And like I said, I didn't really appreciate that until kind of worked with the hospital and heard some of the barriers and the obstacles and the stigma, I think. So... And I know Hep C later, we've done lots of work around stigma and breaking that down. And I think, yeah, it's really important. So.
Thanks. I mean, what would be really nice is if we could just do it on a TTO prescription. So anybody who's got methadone, you just add it to the prescription and the hospital pharmacy gives it out. Similarly, the patients we see in A&E, we give out packs of antibiotics or painkillers to be able to give that out. So maybe we need to speak to NHS pharmacy and just see if that could be a prescription, a prescribable option that we could just put on TTO prescriptions.
Okay. And it's that thing with naloxone is like why are we not giving life-saving medication out? You know, we give, you know, an anaphylactic medication out, like it's fine. Why can't we give naloxone out? I really don't get it. We can save one person's life, but not somebody else's. That's, you know, health inequalities as it's, you know, so. I'll start ranting in a minute. I was all nervous and now I'm all excited.
Very much. Sorry, it doesn't cost very much money, but if we could actually have that on our prescriptions, it might be a way forward. I know there's a lot of debate at the moment about vending machines for needle syringe, and there was one plan to site those in A&E departments. And there was a lot of opposition from A&E because they said, we really don't want a lot of people hanging around just using these vending machines. But if it was actually, as I say, a to take out prescription, it might actually get around that. So I think perhaps that's something we should take forward. Maybe
think
NHS England need to think about it.
NHS England did pose the question to us earlier as how involved do you think we should be? I'd say you could get involved in this. And I actually really like the idea of handing it out non-prescription as well. I think prescription's a great idea, Ashley, but it's also, there's so many settings where you could hand out packs where if you had to say, sorry, I can't give it to you because you haven't got a prescription, we wouldn't want that either. So I think it's a really good idea, really good response to what's happening on the street, which is very limited places where you can get NSP anymore. Seeds being sown.
There could be a patient group directive that means you don't actually have to have a signed prescription for it. But I guess what A&E don't want is hundreds of people just coming up and using it as a needle syringe program out of hours, because A&Es are incredibly busy. That's the only thing I'm thinking about. Whereas if you actually say it's somebody who's come in because they've got an abscess in their leg or they've taken an accidental overdose or whatever, that when you discharge them, you could actually send them out with a pack, I think would be a very good idea. And similarly on the wards, we often have people on the wards who are going out on their methadone script, but just to be able to add it to the take out TTO prescription, that if you're prescribing methadone, you automatically also prescribe naloxone and a needle syringe pack, would strike me as being very sensible.
I mean, I'm just going to add that there's not many drug users who will attend A&E, see how long they've got to wait, and wait for a pack. So you're probably not going to get people turning up for packs, but having them available is such a good idea. It's a great thing I've heard today.
Great. Do we have any other questions or points? Yep.
Just a question for John. I just wondered whether you included staff testing when you went to the forensic unit, and if you did, whether you felt it would help break down any of the stigma towards hepatitis C testing.
So what I sent is the portal. So the portal testing. So I sent that in an email to all the staff in case they wanted. When we did test point of care, test 5 or 6 staff, didn't we? Which then helped with the uptake of people to come in and being tested, didn't we? But yeah, but definitely sent them the portal so that they could do it themselves. So they're doing it from home.
Any other questions? No, if not, then thank you all three of you for some great talks.